We call it virtual reality platform because it's way more than perimetry. Perimetry is probably the one that people knows the most, but it's way more, and you're going to see about it. Next. Based on Medicare data, the average number of visual field tests per month per office is 17, period. That's it. It's one of the lowest, if one of the tests that is used the least. All our doctors, the average of among our doctors is about 44 tests per month. We significantly increase the productivity of the doctors. Next, please. We use different technology, but we focus on virtual reality. Next. The platform is composed by three main parts. First, cloud, where everything is stored, analytics, algorithms. Second, the virtual reality headset, which is what the patient interacts with. And the web app, which is what you guys and your technicians and manager will use to create new patients, order tests, pull up reports. Next. The platform, like I mentioned before, is not just a visual field, which visual field is just a piece of it. And it was probably it was the first one that we developed. But currently, the platform includes 60% of the comprehensive eye examination. So we have acuity. Within acuity, we have near, distance, low contrast. Within color vision, we have Ishihara, D15. We even carry the Wagner color vision. We have extraocular motility. Within extraocular motility, we have more the cardinal position. Perimetry, of course, all the perimetry protocols or strategies, super threshold, 10, 24, 30, estimate, you name it, we have it all. Then we have contrast sensitivity. Within contrast sensitivity, we have two main tests, but the most important, of course, what we use is a Pelly-Robson-like. We do cover tests, pupillometry, and a C-suite that includes, like I mentioned, 60% of the comprehensive eye examination in about 3 minutes. And we're going to talk about it. Next, please. So the reports that we use are standard. We don't want you learning new things at all. You already know enough. So what we would like to do is your job easier. And for that, we develop reports that are standard, follow the standard. The one you have on the right is the C-suite comprehensive eye examination that includes acuity, includes the Ishihara, includes the confrontation visual field, extraocular motility, and pupillometry, and all that in about 3.42 minutes. That and by the way, not 3.42 minutes in terms of just the testing time, is about 3.42 minutes automatically. No human interaction. Annie, which we're going to talk about it, drive the entire show. Your technician now, once they put the headset on the patient, they can multitask. Next, please. So let's talk about the advantages of the platform. First, for providers, for doctors, right? Number one, you don't have to think about where am I going to put this technology. You hang it on the wall. Number two, you don't require a special room to run the test. You can do it in the hall, in the waiting room, or on the examination. It involves minimum technician supervision, does not require any uncomfortable position, which makes the test faster. No need for patching, and the clinical assessment improves. And I'm going to tell you how we improve the quality of the test. Next, please. The reimbursement, you can use the platform for all these CPT codes. The pupillometry is a relatively new CPT code, which is not covered by most, insurance company, but it is gradually increased. So I wouldn't be surprised if very soon it is carried by most of them. Next, please. Clinical advantages. Number one, it's a binocular consecutively test. So it's not like traditional method, first right, then left, which means that now the left eye is no longer in disadvantage. Like there have been several studies that shows that the quality and the sensitivity obtained on OS is most of the time different, not because it is different, but just because it's the second eye to be tested. The quality of the test remains good, even if you have a central scotoma. And the reason why is just because of that, because both eyes are open during the test. So even if you have a patient with let's say, macular degeneration, the quality of this visual field test is still going to be good because the other eye helped fixating. It improves and it provides even more objectivity to the test. For example, if you're going to do the extraocular motility, now it doesn't depend on the capacity or the training of your technician. Or if you're going to do the pupillometry, you don't have to worry anymore about whether you're going to, lose or miss an APD or RAPD or any other pupillary defect because it is objectively done. Another advantage is that Annie provides tutorial to every single patient, and this tutorial is exactly the same. So we're talking about a standardization of care all across. Standardization on the tutorial, standardization on the monitoring, and the feedback that patient receives from Annie. And of course, increase the ability to acquire more data, like I showed in the beginning of the presentation. Next, please. For patient, this is the easiest one. Patients love, in every single one of the surveys that have been published, and we're going to provide you with all the publications so you can take a look at it. The patient's adoption and the patient acceptability of the test goes up the roof. They love it. They don't want to go back to the old technology. So the compliance in their office is going to increase significantly. They don't have to be on an uncomfortable position, right, during the entire test. They don't need, of course, the patch. Now the testing is more physiologic because both eyes are open. The patient can adopt their preferred position, because now when the patient wears the headset, it doesn't matter how much they move their head. The relationship between the eyes and the stimulator remain constant all the time. And of course, increase in patients' productivity because they don't have to wait longer time in your office. Next, please. This is sort of the historical data that we collected since 2021 that we started collecting 2021 our platform saw about 31,000 patients, and last year we saw more than 500,000 patients in our platform. Every month, our platform handles more than 60,000 and keep growing, so of course. Next, please. We have an extensive clinical validation. We give a lot of importance, of course. For us, it's very important that every single our technology is validated before we put it in the market. And we have about 9 peer-reviewed papers plus other presentation, poster, and session. Next, please. Next. And next. Sorry about this. So let's do some comparison with the standard of care. This is a study that was performed, and they compare the HFA with the visual. And in terms of time, it's definitely faster. Now, it's not only faster in terms of the testing time, it's faster in the entire testing experience, because now the patient doesn't have to stop the test, wear the patch, change the patch. It's way more and predictable. Now every single patient received the same tutorial. And by the way, Annie, which is our virtual assistant, speaks 40 languages. So now every single one of your patients received the tutorial and the monitorization of the test in their mother tongue. So that's why the quality increased significantly. Next, please. In terms of false positive, false negative, but the most important is the fixation losses. As you can see, there's no fixation losses, right? So the reason why, it's because we introduce a new algorithm that is called dynamic matrix. And basically what it does, it tracks the position of the eye live. So because of that, there's no fixation losses. Only when the patient moves their eyes beyond 15 degrees, that is when we start counting fixation losses. But that is very uncommon. Next, please. It was also very important, of course, the comparison between age effect. And as you can see, it's a very similar HFA and the visual. Next. The sensitivity for the detection of glaucoma was a little bit better, but not significantly. So we say it's the same. Next. The agreement, we had an excellent agreement with the HFA. Next. And also a good correlation. Next. Reproducibility. This is very important, right? Because one of the problems that we have been facing with the HFA is that patients don't like it, it's very uncomfortable, and in consequence, the reproducibility is low. This is one of the aspects that we have been able also to improve significantly, because for all the reasons that I mentioned before, patients are more comfortable and they don't have against time doing the test. Next. Another example of a good reproducibility of the test. Next. And this is it. This is my information. If you want more, if you want to know more about the technology, feel free to contact us either directly through the email or through the GPOphtho team. Thank you very much, Dr. Matosia and the rest of the team, for the opportunity. Have a good one.